So in general, like in the coming videos, I'll be talking about atrial enlargement and ventricular hypertrophy. So what is the reason that I'm using the term enlargement in case of atria and hypertrophy in case of ventricles? So the reason behind that is that the atria are activated circumferentially. That means here if we have the sinus node, it's going to generate the impulse which will be traveling in the circumferential pattern like this. Okay, so the impulse from the sinus node travels in the circumferential pattern and activates both the left and the right atrium. Therefore, the impulse travels through the length of the atrial wall, and hence we use the term enlargement rather than hypertrophy. The P wave changes in the ECG do not reflect the thickening or hypertrophy of the atrial wall, but rather increase in the dimension of the atrial cavity. Okay, so the P wave will basically represent the increase in the dimension, okay, not hypertrophy. And that is mainly related to the way in which the impulse is conducted, which is circumferentially. So we'll be talking about the distance this way. Whereas when we talk about the ventricles, the activation of the ventricles occur from the endocardium to the epicardium. This is something that we've already discussed previously. If you're not clear with that, you can just see my previous videos. So that being said, in case of ventricular muscle increase, we can use the term enlargement or hypertrophy. Okay, but in case of atria, we will use atrial enlargement. So the first thing that we'll be discussing is the normal P wave. So we will be discussing the atrial enlargement first, and then we will shift on to the ventricular hypertrophy. So before doing the atrial enlargement, we need to know some parameters about P wave. So the P wave can be viewed in terms of the frontal plane and in terms of the horizontal plane. So if we know the specific things about the P wave when it's produced in a normal heart, it would be easy for you to know what are the changes that have occurred in case of left atrial enlargement and in case of right atrial enlargement. So that being said, when we talk about the frontal plane and the horizontal plane, by that I mean to say the frontal plane is the plane in which you have all your limb leads, and the horizontal plane is the plane in which you'll be having your precordial leads. Again, this is something that I've already covered in some of my previous videos, so if you want to have a look into greater details, you can just pause the video and go back to those videos. Anyways, so in the frontal plane, we need to know that the normal axis of the P wave is approximately 45 to 60 degrees. Okay, so it's almost like 45 to 60 degrees. Thus, the P wave is upright in lead 2. So if you see at this little diagram on the upper right corner, you will see that the positioning of the lead 2 is almost at plus 60 degrees. Okay, and we talked about the axis of the normal P wave, which is around 45 to 60 degrees. So therefore, if we really want to know about the P wave's morphology, lead 2 is the best lead to look for because it will be getting the maximum current in it. Okay, so the most important lead in recognizing that the rhythm is normal sinus is lead 2, which will have an upright P wave since the direction of the vector is directly towards the recording electrode. Okay. Now, if the P wave is not upright in the lead 2, let's say that in the lead 2 it's this way. So that means that the P wave is probably ectopic, that is, it is not of sinus node origin. If it's of sinus node origin, it has to be upright, which is shown here. Okay, so this is the importance of knowing whether or not The lead 2 has an upright or an inverted P wave in normal heart. Next, when we come on to the contour of the normal P wave, it's smooth and well rounded. Okay, it should not be peaked or notched. So that's very important, that it has to be really smooth and well rounded. Just you can see here, so it's quite smooth and well rounded. Okay, so now coming on to the amplitude and duration, and it's very easy to remember the number here because it's same for the amplitude and the durations. So in both the cases, it has to be less than 2.5 mm or less than 2.5 small squares. And it's the same even in case of duration. So now coming on to the horizontal plane, we have the precordial leads from V1 to V6. Okay, now we need to know that the sinus wave, the sinus P wave is normally upright in V3 to V6. So it's gonna be upright. Okay, and in V1 and often in V2, the contour of the normal P wave may be upright, it can be inverted, or it can be biphasic. Okay, so this is something that's shown in the figure above, that the P wave morphology in the lead 1 can be upright, it can be biphasic, and it can be inverted. So the biphasic means that the initial portion of the P wave is upright and the terminal portion is inverted. Okay, so that is what the biphasic means. So in general, if we see in the frontal plane, lead 2 is the best lead to see the P wave morphology, and it's always upright in this lead. If in lead 2 the P wave is inverted, that means that the P waves that are being generated are not of sinus node origin. It's being produced from some ectopic region, some other part of the atrium. And when we talk about the horizontal plane, we need to know that in general, from leads V3 to V6, the P wave is upright, whereas when we talk about V1 and sometimes in V2, the P wave can have different morphologies. It could be upright, inverted, or biphasic. By biphasic, I mean to say that the initial part of the wave is positive and the second half is gonna be inverted.